So we're going to open the last session for today, and we have 3 excellent speakers, and we're going to try and do this in a very timely fashion so you can still get out and breathe before dinner tonight. This whole session is based on clinical trials, and our first speaker, Dr. Daniel Rayson, is actually a medical oncologist from the Queenie 2 Cancer Care Program. He's actually the director of the Atlantic Cancer Research Unit, professor of medicine in Dalhousie, all the way here from the other side of the continent in Halifax. Daniel?
Now, some of you may know this fable, The Blind Man and the Elephant. So I'm just going to read the first paragraph. It was 6 men of Indostan, though to learning much inclined, who went to see the elephant, though all of them were blind, that each by observation might satisfy his mind. This has been a bit of the story behind neuroendocrine tumors, where you have lots of different specialists all coming to the elephant in their own way. So the endocrinologists and pathologists, being the smartest of us, probably hang out by the head, right? Safety, close to the brain. The surgical colleagues who tend to tackle the most difficult issues hang out by the trunk. Lots of danger, lots of problem solving. And I won't tell you where the medical oncologists hang out, and I'm very proud to be of that notion. But clinical trials force us to talk the same talk so that we get less blind because we start to evaluate things in a standard, organized way. The next 5 minutes is going to be about just very broad brushstrokes, the evolution of clinical trial paradigms in GI and neuroendocrine tumors. So one of the first studies that examined the role of chemotherapy was studied by the Eastern Cooperative Oncology Group, or ECOG, and just notice when it was published, 1984. Patients were accrued late 70s to early 80s. The methods of assessment were really a clinician figuring out if the liver shrunk or grew, primarily. This is not a criticism, it was just a standard of care at the time. But amazingly enough, studies like this define the role of chemotherapy up until today. The Mayo Clinic was a pioneer in publishing their experience in a variety of different treatment paradigms, and this is one that was published in 1994, a consecutive series of patients at the Mayo Clinic who underwent hepatic arterial occlusion or blockage, and then a subset of those went on to have chemotherapy, and it was observed that those who received chemotherapy seemed to have control of the disease longer. Now, this defined the standard of care, and it's only now that a confirmatory study is being run out of the Moffitt Cancer Center in Florida, almost 20 years later. Even the PROMID study, which has become a pivotal study in our understanding about the role of somatostatin analogs that you're going to be hearing about more, was plagued with some difficulties. It took 7 years to accrue half the number of patients it was planned to. And although it has defined a new standard of care, it just goes to show some of the struggles that have evolved historically in the understanding of clinical trial design in GI and neuroendocrine tumors. So what's changing? And what's changing is a huge concerted international effort to better define things, better define the disease, the clinical situation, and the outcomes. So again, I don't want you to concentrate too much on anything, but note a couple of things in green. Progressive. When you're dealing with a disease that we know for a certain proportion of patients has a long period of stability, it's very difficult to integrate that into objective responses. And if there's a bias one way or another, if one group has a lot more patients who are destined to have stable disease, that might influence results. So a lot of the trials now build in this necessity for disease progression. Look at the green as well. Just as you heard in the last talk, interim analyses are now being built in, whereby the data is examined at a pre-planned set point at different time points by an independent committee, nothing to do with the trial, to decide if the trial should continue either by safety or efficacy. These are huge advances that have been standard in general oncology clinical trials, but only now are becoming rigidly incorporated in neuroendocrine tumors. And note also that the sample size, these trials involve 5 times as many patients as previously. This is a similar study, Radiant 3, again, progressive pancreatic neuroendocrine tumors with incorporation of a crossover. And this is a term that you'll hear about if you do any searching on clinical trials, about a crossover design whereby if there's a placebo arm, at progression, patients can cross over to an active treatment and the results still incorporated in a way that makes sense. They can be analyzed and translated in terms of clinical care. And the last trial, which you just heard about, again, very similar. Very clearly defined endpoints, progression-free survival, clearly defined secondary endpoints, all with progressive disease and all with appropriate interim analysis, which led to an early release of trial data and a closure of the trial. So there has been a huge frame shift in the way we think about this disease in terms of clinical trials, and the future is only going to be brighter in this domain. But there remain a lot of challenges. So when we talk about GI neuroendocrine tumors, and you've heard a lot about this, but between the relative rarity, and again, we're not convinced that's the case much anymore, the prolonged symptomatic or asymptomatic period before diagnosis, the symptoms that overlap many benign conditions, the syndromes that can outweigh the bulk symptoms for many, prolonged survival in the absence of treatment for many with indolent disease, issue of carcinoid heart disease, the concept of inherent chemorefractoriness, and the role of radiopeptide-based therapy, which is, again, a totally different type of treatment. There remain a lot of challenges, but I think the future is that slowly but surely these will start to be looked at in a very organized fashion through rigorous clinical trial methodologies. So the historical frustrations, last slide, in evaluating therapies really have been two. Lack of adequate randomized trials, and I'm sure for those patients in the audience and their families, it's been a real frustrating issue for you, especially if you go back 3-4 years, to try and sort out what's real versus what's not. And very importantly, the power of the anecdote, the single case. And hopefully in the future, based on your participation and your family's participation, both for yourselves and for those to come, a lot of these issues are going to be solved. So thanks very much.